This presentation is a continuation of a previous presentation I gave with focus on the prevention at population level. This one is focused on treatment. And we're going to have a hopefully time at the end for a quick discussion in trying to address 10 key research questions made by top scientists worldwide, published on Lancet in 2017. It's 5 to 6 years old, but still very updated set of questions, because I don't think we have answered those questions yet. And there's plenty of room for research in diabetes. And with a growth in our own department, our own medical school, of much access to data like we never had before, I hope that we can have more conversations how to use that data to leverage different types of research than we would have been doing before. So the presentation, we start with a very quick review, because I've done it before in previous presentation, and it's a kind of a repeat, a little bit much shorter, of the burden of type 2 diabetes. We're going over very quickly, a very top, but not detailed discussion, the genesis of diabetes at the individual patient level, and the genesis of the epidemic of diabetes happening in America and the world over the past 30 years. And then we're going to talk about treatment innovations. And there are two kinds of treatments we're going to focus on. One is something that people call treatment with the objective of reverting diabetes and trying to get patients to remission that's kind of permanent, or at least for long term. And then the absolute majority, which is not that, which is just how to manage a patient with diabetes like we used to be when I graduated from medical school in 81, which basically said, hey, once you have diabetes, you have it forever. So there's multi-evidence this has changed, but not much in reality. It's changed theoretically and in some exceptional cases, but absolute majority is still difficult to revert it. So the burden of diabetes, it's staggering. This is data from nearly, I would say, 5-6 years ago. It's much bigger. It's probably around $34 million right now. And I think the next slide, the next slide gave it away. There's 34.2 million people have diabetes, and estimated 27 million have been diagnosed with diabetes. Of the people diagnosed with diabetes, 210,000 are children and adolescents younger than age 20. Why I wanted to bring that point, because until about 20 years ago, it was unheard diabetes in children, meaning type 2 diabetes. Type 1, no, it's expected that would have a few children with diabetes type 1, as well as some teenager and some young adults. But type 2, no, it was unheard of until about 20, 30 years ago. And then the Boogaloo study, they used data from Alabama and some other southern states, opened that can of worm, basically saying to the American researchers and physicians, hey, diabetes here in children, type 2 diabetes, that is. Undiagnosed, huge numbers, over 7 million older than 18 years old have diabetes, but undiagnosed, about 22% of the population. On the genesis of type 2 diabetes, again, I'm going to be very brief and very general. It's a multi-causal. It's part of the what I call cardiometabolic chronic disease and condition. At the individual level, multiple causes, and they all linked, especially cardiovascular, like CHD, coronary heart disease, stroke, and type 2 diabetes. But all the other conditions I mentioned here have some way or the other same risk factors, and some of the same pathological pathways may be shared. Evidently, this is a very general, and there's more detailed models made for each specific disease, which I'm not bringing up at this point. And a more focus on diabetes itself as opposed to cardiometabolic and other related conditions, you would have this kind of a nice pathway, which is more detailed. And I want the physicians in the group to pay attention to it, because sometimes we're talking about it, they're not going back to the basics. But if you talk about no modifiable, modifiable, clearly obesity, low physical activity, and unhealthy diets are modifiable risk factors. We can do something about it in terms of prevention, as well as in terms of changing the lifestyle of a patient and trying to get it to either prevent an imminent initiation of diabetes type 2 or totally revert one that's already just started at the beginning. More chance at the beginning. We can get a little bit more information later. But these are some of the more in the cell type of mechanisms. I'll give you a little bit of the overview later on. But the reactive oxygen species, endoplasmic reticulum, advanced glycation end products, protein kinase C, lipopolysaccharides, and microRNA are big areas of research right now. I don't do that type of research, but I list them here because they're all part of the pathogenesis of diabetes. So for those who are in the biolabs of the School of Medicine at Mizzou and others who are attending this lecture at this point, think about it. There's a much research to be done here too. All these factors, the so-called non-modifiable and modifiable combine and at the cell level to cause what you call diabetes, which is defined as a metabolic disorder causing sugar in the form of glucose to accumulate in the blood rather than being used as fuel by the cells in our body. And a little bit more of that, but more like, bird's eye view. In a healthy person, insulin helps turn food into energy. Stomachs break down carbohydrates into sugar. Actually start breaking down in your mouth through the amylase, which gets your starch that they eat, which is basically sugar, and breaks down into a small molecule. They enter the bloodstream, prompt your pancreas to release the insulin and just the right amount in a very normal, healthy person. Insulin attached to cell receptors in the liver, muscle, and fat tissue to help your cells use the sugar for fuel. There's a whole mechanism. I'm not going over that. You can go to a typical endocrinology lecture and get all the details, how that happened, all the receptors, and how that unfolds. In the end, in your vessels, what you have is this exchange all the time. In type 2 diabetes, your cells can't use the sugar. That means there's a lot of it in the blood, and you have a condition called insulin resistance, which makes your body makes the hormone, but your cell don't use it or respond to it like they should. Therefore, the sugar accumulates in the blood. If you had type 2 diabetes for a while, but haven't treated, your pancreas will make less insulin. That's another consequence. In addition to have a lot of glucose in your blood, you're actually sending message to your pancreas to fabricate more insulin, because it's not being used. Remember, there are a lot of stuff going on here. I'm not going into the details, but once you have a situation like that, first off, sugar is not being used. It's in the blood, but it's not being used by cell. The body, each cell in your body is telling your brain, hey, I'm hungry. So you're hungry. You're eating more. The insulin resistance is forcing your kidney to overwork. You have lots of blood circulating, and then this fabrication of excessive insulin makes your pancreas wasting the cells itself. And over time, you develop a loss of ability to fabricate insulin. So there's a lot going on here. Your thirst, everything is related to that sugar. You urinate a lot because it's the osmotic pressure, the sugar. It's soluble in water. It brings the water with it. Polyuria means you urinate a lot and you dehydrate. It's just a lot of stuff. And you'll go hungry. So these are the early symptoms. Once you have symptoms, you already have a disease that's been developed in your body for a long time. So symptoms are the late stage of a process, a metabolic process going on for a long time. So the genesis of the epidemic is a little bigger picture, not at the individual level, at the population level. So what's going on at the population level? Well, you can use any mechanism, models, mechanistic models to explain that, but a simple one is the one by Egger and Swinburne. It's for every disease, actually infectious and non-infectious and everything. So you have this interaction of environment, agent and vectors, and the host, that's you. At the host level, you have education, psychology, medical intervention. All these things affect you directly, but you also have the agents that's causing that. Is that an agent there? Is temperature part of the problem? I'm not going to get into that. Yes, it is. It's the physical space around you part of the problem. We're going to see a little bit of that. Yes, it is. And then you have policy, social change, legislations, a lot of stuff going on. In the end, you have all that resumes to the key epidemiological identifiable risk factors. Doesn't mean they cause the diabetes, but they're contributing, or the real risk factors causing diabetes: dietary behavior, physical inactivity, and overweightness and obesity. These three, especially overweightness and dietary behavior, are strongly linked with the development of diabetes. Any cohort studies ever done. Then you have, like I said, dietary behavior. A diet low in fat, which by default is high in carbohydrate, becomes the standard recommendation guidelines in the US and later around the globe. This has been the truth in America for the past 40 years, since 1964, I believe. Okay, and that means increased consumption of carbs, increased consumption of sugar, sweetened beverage, continued low consumption of fruit and vegetable. I point you back to a presentation we made on sugar sweetened beverage. I made a presentation around this publications I had about 7 years ago on this issue. It has a very high citation level. It focuses on the policies about sugar sweetened beverage. It's very interesting. And you can find in the previous presentation or go to the publication itself. So reduced physical activity, absolutely. And all these things together will lead you to obesity and insulin resistance at a population level. That's your obesity, your cutoff. Just a point here, until about 1992, 91, you had cutoffs to define obese people based on the distribution of body weight and height across American of all ages, especially adult age, and you have one for children. About that point in time, top researchers at NIH and CDC modified that by adding the issue of the risk of what level of obesity or overweightness increase the risk of developing diabetes, of dying from diabetes, of dying from heart disease, of dying from something. And that's what you have here in this BMI cutoff. It's all being associated. So these studies on the association between body mass, meaning obesity, body mass used as a proxy for obesity, and diabetes, as well as other cardiovascular, became stronger, actually. The relative risk became stronger also once they start using this new cutoff for BMI. So clearly obesity is a big culprit here, and we still don't understand all that it takes. I am not going to focus on that. It could be another lecture. I'd love to go over that with some of you. But what the end result is this. Overweight, it's pretty much stable. The obese, it's going high, immensely high, and the extremely obese is going high among men and women. Again, the same pattern. It's even crossing over. The obese is even greater, and the extremely obese is very high. And the most worrying and troublesome is the children. Worldwide and in US, you have an incredible increase in overweightness and obesity among children. And that's very, very, very troublesome. How am I going about time? Oh, we have spent already nearly 15 minutes. So let's talk about the innovation in the treatment. Again, this is a companion presentation, or earlier presentation I made, focused on the prevention. So let's focus on treatment that supposedly could revert diabetes, okay? So I could summarize them in two types of research, basically. Bariatric surgery and low-cal and low-carb type of diet combination. They're the ones that have the greatest evidence, stronger evidence by far. So the bariatric surgery has been found to be superior to the intensive type 2 diabetes medical management in practice. And in a short term, you have seen reporting as much as 80%, reversal of diabetes, type 2 diabetes, that is, with an additional 15% demonstrating partial improvement in type 2 diabetes. That's huge. That's 95% of the diabetic person in those studies having benefited from bariatric surgery. I have an example of my family in which I made a recommendation for one of my brothers to go to bariatric surgery. He is 6'4" in height, but he has 170 kilograms. And he's clearly at risk for some of those diseases. He's only 60 years old and beginning to have a bad A1C, but not so bad yet, in high blood pressure. He didn't do it. He didn't want to do it. And then my niece, who is just slightly overweight, did. And she was only 18, and she's now 10 years later, even worse than before. So I'm giving the point here to make the point that not all beautiful things work like we expected. So over time, type 2 diabetes remission rates remain high, but do decline over time, like in my niece. 3-year remission rates of 68.7%, so it's pretty high, still very good. 10-year remission rate, remission is like remission from diabetes at 83%, still very high, but this is among the people who had gone through the surgery, okay? So, but that means you lost close to 20% in one casuistic, and the other one you lost close to 30% of the case. That means they became diabetic again. A 72%, 36% recovery rate for our from the surgery at 2 years and 10 years has been reported also. So overall, it's a powerful and effective, but there is a high number of people, even though the remission rate is high, it doesn't mean it's that good. On the first casuistic here, you can see it's 30% revert back to diabetes, and about 30% and 70% in some others from depending on how long you follow them up. So it's not perfect, but it's very powerful and very effective. It actually reverts diabetes, meaning a person A1C is normal, and things have changed dramatically. What about low-calorie diets? What's the evidence on that? It's pretty high too. And I would just say that this paper here by Hallberg, kind of a narrative review of the evidence published in Nutrients, does a good job in summarizing the main effect. And I would say this is a level of evidence that I would consider to be moderate to high, that there is possible reversal of diabetes. But the point is, these are clinical trials, have not been attempted at a population level, and to see whether how many people can actually accept that. And the fact of the matter is, the absolute majority of the people who are diabetic do not go through those treatments, either treatment. So reversible surgery and low-cal and carb restriction are better summarized in these papers that I gave you here. And you can see that there is improvement through A1C going dramatically down, but it's coming back a little for all of them. And for low-cal alone, it's not that good when you compare to sleeve or bypass, meaning the low-cal and the low-carb combination does have some effect, but it's less impactant than the effect of the bariatric surgery, either through the sleeve or the bypass. There are two techniques, surgical techniques, to resolve that issue. After 1 year, they start reverting back on the bariatric, and for the low-cal alone, start reverting exactly at 1 year, and for the low-calorie and diets only, start reverting at about 3 months. Innovations in the treatment of type 2 diabetes focus on managing type 2 diabetes. I'm going to focus on this presentation on basically I'll say three technologies. One of them, we are able, the HIDR, this network that's presenting the seminar, we're able to help researchers to do some summary through 2 meta-analyses, and I'll summarize them again, meaning the overall health information technology impact on diabetes. And the other one is the other, obviously, gadgets, but helpful tools using electronics and digital technology to help managing diabetes, not with the intent fully of reverting diabetes, but just to manage and keep the A1C lower than it should. But to just remind again, there are many reasons why the reversal or even attempting to intervene may not work. And not forget that beta cells may have been damaged, and underlying genetic factors contribute to person's susceptibility may remain intact. Therefore, you don't expect much change there. Successful diabetes management requires people create new habits around medication adherence, glucose monitoring, and dramatically change their diets, exercise, and more. Poor adherence to lack of integrated care in many healthcare systems, including a clinical inertia among healthcare professionals. It's very difficult to have integrated healthcare. I think our healthcare KMU is a pretty good example of one that actually trying to integrate as much as we can the primary care and the specialists, and have the primary care doctor being very sufficient in delivering good care, for, even for patients with diabetes. And then you have critical patients' belief about their medication and everything else around their treatment. It may affect tremendously. And if we don't understand for different populations their levels, we don't know what we're dealing with in that community. And it's like a contagion. Once people in a community believe it, a majority of people believe it. So we have to learn that. Perceived patient burden regarding obtaining and taking medication. Sometimes not even the truth, but it's their perception. And some of them are truthful, like have out-of-pocket costs. All of these and the complexity of it may affect how people strictly adhere to a regime, a treatment regime, or prevention and reverse a treatment regime. So all these factors are playing a role. And we end up with a large population that what we want to do is to improve their quality of life while they're having diabetes, through improvement of HbA1c, which A1C, I would call it, reduction in hypoglycemia stage. You don't want patients oscillating between hyper and hypoglycemia. Very dangerous, very common in type 1 diabetes. That's not well managed, but if you manage well type 2 diabetes, you should not have that. And the continuous glucose monitoring and insulin pump becomes the key issue here. And that's why I'm presenting a little bit about them. And then in my review of HIT, there's a little bit of the smartphone apps, actually not a little bit, a lot, I should have said, because the HIT technology review, and I'm going to show the results again, but very summarized to you. Absolute majority of smartphone kind of based. And flash glucose monitoring is another one that I'm not presenting any of the examples, but it's part of the process to deal and manage diabetes. And this is a presentation, by the way, meant for the novice in the area of diabetes research, or the postdoc person in epidemiology or health informatics working in this area. But it can be a refresher for some early career physicians doing research on diabetes. So individual information technology, we talk about Bluetooth-enabled glucose meters, continuous glucose monitoring, self-monitoring, smart pen, insulin pen, with or without the support health app. Instead of presenting this at the end, I'm presenting right now for this little summary, the result of this paper, which kind of summarized very well our knowledge base on that by Grant. And basically says there is evidence to support the use of technology to improve the management and treatment of people with type 2 diabetes. Further research, however, is required to demonstrate the long-term clinical benefit and financial viability of technology in the management of type 2 diabetes. When he wrote that, it's only a few years back, I think it's 2019, it's only 4 years. The price of some of those tools have gone down tremendously. So I think the financial viability may have proven now to be okay. Is a long-term clinical effect still we need to look at? But that's the summary that's still prevalent today. I will have nothing else to add in the research of these items specifically. So what we're talking about, self-monitoring glucose and continuous glucose monitoring, they are about the same thing, but they are different. One is continuously monitoring. That's what the focus is on this presentation. And the other one, you kind of the patient initiate the monitoring or the metric metric continuation. So you can find these good publications. Does a systematic review and meta-analysis that also contribute and provide these numbers here. And the meta-analysis, they pull data from 5 RCT showed that continuous glucose monitoring was more effective in reducing A1C than self-monitoring glucose monitoring. And that's why I'm going to introduce, for those who are in information technology, a list of those issues that are now being used and being available for physicians to use. The technologies being used for doing glucose monitoring, continuous glucose monitoring, that is. So non-implantable, we have the simple auto applicator, use of factory calibrated flash glucose monitor. And there's one example. By the way, I'm not endorsing anything. Please, I should have put a disclaimer there. These are just the one that I found available. There are many like that. And I'll give in the end a table to lots of different makers. Sensor and transmitter, a circular sensor containing a thin fiber is inserted in the upper arm and record the interstitial glucose every minute. Use a handheld reader or near-field communication enabled smartphone to scan the sensor result in the production of an ambulatory glucose profile. Provide 8 hours worth of glucose values are stored by the device. And you can see more in this publication here. So that this is the implantable, the non-implantable. A continuation of that, we also have the one-touch applicator, and the sensor and transmitter is a little different, slim sensor, and the display device is small touch screen receiver to compatible smart device display real-time glucose. They're actually cool. I wish I'll be practicing again in medicine. I'll be recommending my patients to be using these because these publications speak very highly of this technology, and they're quite readily available now, and they are not so much expensive, and most health insurers are covering a lot of them. So on the implantable piece, you have this small cylindrical shape. This is the typical, and these 3 publications can give you a little bit more on that. 2 examples, the Eversense or the SensoSense and Inc. is one example. A small cylindrical shaped sensor inserted in the upper arm by a trained professional. They transmit through a wearable transmitter, and a smartphone app in compatible smart device displays accurate reading up to 180 days. That's huge, okay? And there's even big advertising on the internet, you know, on that everywhere you open the internet is pushing that advertising. So you have all these differences. So I'm not selling anyone specifically. I'm listing a lot of them here. Currently available continuous glucose monitoring for people type 2 diabetes. There are tons of it in US, in Europe, and everywhere. Okay. I mentioned the example of the Eversense, but there's also Glucoman, Dexcom, and so on and so forth. And then for the insulin pen, which you didn't go through in much detail, but basically it displays the time and dose of last injection. It has a battery life and memory status and allow you to this pen to inject your insulin for the patient who's dependent on insulin. It's very helpful for the type 1 diabetes, but it's also for patients who are in advanced stage of diabetes in which the insulin resistance is so high, their glucose level is uncontrollable, except if you use insulin. And there are many makers of the insulin pen. Conscious of my time, I wanted to give time to have a discussion of 50 minutes later. So these are some of the technology I'll describe here that I wanted to highlight because they are the one that the literature, scientific literature that is, shows more evidence of being helpful to manage diabetes is the continuous glucose monitoring and the insulin pen. So on the individual technology, taking everything, especially smartphone apps, smart scales, telehealth, 3D technology, and the digital world in general, there's this publication for NIH, which is only about 5, 7, 6 years old. They say the level of evidence is at best moderate. And then about 3 years later, about 4 years ago, we've done 2 meta-analysis, and I think we added a little bit more to that moderate. I would say that's a little bit over moderate, the evidence for this technology to be very helpful and keeping a patient with diabetes with A1C at the levels that's considered to be healthier for that patient. And that's what I'm going to present today. But remember this presentation, that's NIH guidelines. It's big. It is only 6 years old. F215 is one of the papers, but also this publication, I think, is about 217, 219. So we done one meta-analysis, which is summarized here. You can see the publication here, and as presentation is available to you, you can click on this site, you get the full publication. But it clearly shows in here, these are the standard deviation for the I can barely read it. That's the mean standardized difference in means, not standard deviation, standardized difference in means for A1C with the intervention across many interventions, multiple intervention, and your average reduction is pretty high, actually. It's almost similar to the one with treatment with medication. And I summarized this in this sentence here. A1C percent reduction average this much with values range from this much to this much. Okay, this is the hedge which adjusts for biases. And the main conclusion of that is that implications of an average reduction of 2.1% in A1C in comparison between metformin monotherapy and placebo. Metformin reduced A1C by 1.1%. Other studies have shown 1%, and so on and so forth. So it's pretty high level of evidence. I consider that, but it's only one meta-analysis, and this review by NIH, it shows a lot of other meta-analysis, and it's only about 4 years in between that review and this publication that I had. But you can review that. On another publication, which is another meta-analysis, we reviewed the HIT, those that I listed before, effect on A1C for diabetic patients developing having cardiovascular risk factor. What's the impact of that on the reduction prevention of the risk factor for them? And it's pretty high also. And the publication is here. You can find it by clicking on that link for the DOI. I would summarize that, say that HIT appeared to achieve equivalent, even slightly greater effect for some of the lifestyle, unable to fully separate the effect of HIT from possible medication administered. The trials are not clear enough on the medication, so it's possible that this high effect is because it's mixed indirectly with some of the medication. Did not report more smoke, and so that's another factor could not be reviewed in the papers. But you can read and make your own conclusion. I concluded that, we concluded, the research in this group, that the combined HIT in standard care was associated with the reduction of the main risk factor. This finding suggests HIT should be used in combination with standard treatment for greatest impact on type 2 diabetes and related outcomes. So the evidence for high information technology is very high, either for smart-based digital type of thing, as well as those that I reviewed in the slides before on continuous glucose monitoring and the use of pen. So you can have this available. I wanted to give 50 minutes for the last slide discussion with some of you. That's my goal. But I would conclude from this presentation, which is a very summarized view of a lot of information, that type 2 diabetes is becoming the most expensive health issue by Americans today. Also concluded there's a clear evidence that type 2 diabetes is preventable at both individual and population level. And by the way, this conclusion is not from this presentation, it's from the previous presentation. It's a cumulative effect of my conclusion. But the adoption of the necessary change to implement those individual level and population level strategies have been very slow, and nothing has changed much in 5 to 6 years on that account. There is also mounting evidence that type 2 diabetes is mostly a body adaptation to risk factors, therefore potentially reversible, permanent, you want to call it reverse diabetes, or permanently have the person remission because the person already had diabetes. So it's an adaptation, like many adaptations in the human body. The starvations of the past allows our body to have this avid desire for some things to happen biologically inside your cells. And that's part of the diabetic process. But also the fact that for 40 to 50 years, we've been bombarding our bodies with excessive carbohydrate diet and very low fat diet may have had consequences on human beings that have eaten a very balanced, not so much carb and a lot of more fat in the diet for nearly 300 to 400,000 years. There's also mounting evidence that it's possible to have reversal. And we show here many researchers in summarizing 4 slides of bariatric surgery, as well as low-carb cow and low-carb diet combination. They are actually able to revert diabetes if you consider reversal to have permanent or for many months or many years, A1C within normal range, not pre-diabetic range, normal range. That's what these studies have shown. It's possible. Is it reasonable to expect maintenance of that? That's questionable. I'm not saying no, but I have my own personal example. It's a biased example of my niece. Also, not all the right people are going to the bariatric surgery. She is a good example of a person who should never have gone to a bariatric surgery. She would be amenable to a lifestyle change like DPP, who certainly would have had an impact on her. She was very young when she did the bariatric surgery, and she's now bigger than one before she did the bariatric surgery. And my brother, who could benefit, is now have developed diabetes and hypertension, and he's clearly morbidly obese. So, but reality is that majority of type 2 diabetes, because the example I gave, would benefit from better managing their condition. And therefore, we need to focus on how to manage that. And that's what the research we did, supporting a few researchers here in our network that did those 2 meta-analyses. And we found the evidence is pretty high for health information technology. And I think there's more to it, that we can find solutions for issues on the managing patients every day that could use health information technology better. We only touched the surface, I think, with that research. And, Dr. Kim, who just introduced, is doing research on that, and many of us are at the moment. And we should be able to bring some new insights in what should work better in this realm. Is also, among adults with diabetes, we also know the HIT use was lower. I didn't present that data, but I have a publication at the end. It was lower in those who were older, belonged to a racial minority group, and had very few years of education, and had very low household income. Well, that's a pretty large proportion of the American population, about 25% to be exact, give and take 5%. And that's a huge number of people. And this is coming from these papers. It's a prevalent study. It's a very well done study that shows that the use of HIT technology for diabetes is very low in this group, meaning those benefiting from those HIT we did and do not include these people. So that's more research needs to be done in this area of equity. So it's almost like the inequities that have been going on for years in the medical system for many different reasons, not inside the medical system. Many of those are outside the medical system, have percolated and forced its way even into HIT, because we're using clinical patients to do that. But those who can benefit are those who have high income, high education, and who are much younger. I mean, I'm not helping everybody. So that's an area for research there. So this is a good conclusion, actually, because what I have that I would like to spend my next 15 minutes is trying to have a discussion with some of you about those 10 research questions generated by Lancet in a master paper in 2017, which I think still have not been resolved. Like I showed to you, there's reversal of diabetes, but it's only a few studies. Some are very strong and came together in a meta-analysis, but not long-term yet. So we still need more time on that. So the questions, I'm going to read them all quickly for the next 5 minutes. So we have left 10 minutes at least for discussion. I wanted to leave 15, but at least 10. Can type 2 diabetes be cured or reversed? And what's the best way to achieve that? How do we identify people at high risk for type 2 diabetes and help to prevent it? What's the best way to encourage people with type 2 diabetes, whoever they are and wherever they live? How do stress and anxiety influence the management of type 2 diabetes? How can people with type 2 diabetes be supported to make a lifestyle change? I think the DPP answered this question, and it was presented before 2017, but this group of renowned researchers found that that's not being answered yet. I think it has, but that's a question for you all to answer to me. Why does type 2 diabetes get progressively worse over time? You know, it's supposed to affect to slow it down, this progression. Should diet and exercise be used as an alternative to medication? That's what the DTP is showing. It's in our face. And also some of the population-based studies show it's changing some incredible change in some communities, very small numbers there is, but it's still change at the population level. What causes nerve damage in people with type 2 diabetes? We still don't know. It's interesting. How can psychological and social support best be used to help people with or at risk for type 2 diabetes? And what role do fats, carb, and proteins play in managing type 2 diabetes? It's part of that diet panacea we talked about before, but it isn't clear. Okay, I went too fast on those because I really wanted to leave time for some of you ask me questions, going back to a slide or not, and just go off of these questions and have a question and answer session. Thank you. Dr. Kim is all yours.
So thank you, Dr. Simoes. I'd like to take your questions. Oh, okay. I can.
Any question about diabetes or HIT and diabetes?
So there is a question from Dr. Hyojang Jung. So he has a question related to the physical activity. You mentioned earlier in the presentation, dietary and physical activity as a modifier factors. However, only bariatric surgery and low-carb dietary have been discussed. Were you not mentioning physical activity because it is already accepted as a reverse to reverse the type 2 diabetes, or because there's not much evidence?
Yeah, it's a combination of both. Like I said, this is a second presentation on the same topic because I could not present all together. In the previous presentation, you would see how physical activity and diet have been used effectively through the DPP to prevent diabetes. But for treatment of diabetes, the low-carb diet and the low-cal diets, numbers I show in this presentation are the only strong evidence that there is for physical activity or diet. But in the prevention, both physical activity and diet have been shown to be powerfully effective, but they're combined. They're not alone. They are lifestyle change type of treatment and interventions. Are there other questions?
Thank you, Dr. Simoes, for your presentation. I have some idea about the research questions in your last slide, specifically the second question, how do we identify people at high risk of type 2 diabetes? I mean, I'm thinking about maybe we could use machine learning and, for example, neural network to identify those features or factors that we might not think they are related to the risk of type 2 diabetes. But through machine learning, we can find those variables. And maybe the next step is like use logistic regression, also in machine learning, to build a model that can predict if a person is likely to have type 2 diabetes or not.
Excellent. Dr. Lee. We do have some research ongoing over the past 3 years here in our own medical school and engineering school on that exactly issue, on using machine learning to predict diabetes. We have not come to fruition yet, but we are continuing it. We have put a proposal, and hopefully we'll be able to conclude that study. But there are many ways. Machine learning is so vast that we can have different ways of approaching the same problem and finding actually different results. And that's why I would like to see more. So I commend you for bringing that up, because it's certainly an area of identification. The caveat is through very simple epidemiology, we can identify people at risk for diabetes. And we already have ways of doing that in the clinical practice. Almost every primary care physician and endocrinologist over the past 20 years that sees a patient who is obese, overweight, should be thinking, and they are, about diabetes. So the phenotype of the patient and their history and their habits could give away they're at risk for diabetes. So we know that, in epidemiological, there's plenty of studies show relative risk for marginal obesity, just overweightness, lack of physical activity, excessive dietary intake of carbohydrates. And so there's prediction already, but it's not practical. It's not comprehensive. It is too close in time to the development of diabetes. So what my group worked with me for the past 3 years trying to do through machine learning is trying to predict in a much earlier time. We talk about when you are a child. That's what we're trying right now, so that we can really understand whether it can be completely predictable, and therefore we can try the prevention more effectively. The existing prevention strategy work, but they're not working too well. They're not being broadly adopted. There's a lot, if you want to learn more about that, the previous presentation is available to you that has covered the prevention piece at the individual level and population level. Or I can send it to you, you can send an email, send it to you. Okay? But that's a good way to go about it. Thank you, Dr. Lee. More questions?
So, Eduardo, what do you think about Ozempic?
About what?
Ozempic, the semaglutide drug. That people take.
I'm suffering from, you can see my voice. I have my both ears
so
plugged.
Ozempic and
Ozempic. Okay,
yeah.
the medication. Okay, Ozempic. It's a very powerful medication, but I had to review, actually, for personal reason. I have reviewed the literature on that, and I'm very worried that most people using Ozempic, they're not the people Ozempic is supposed to be used for. And the medical complications, interactions, and side effects are huge and very, very serious in some people. So I don't know, Mihail, the average person out there who wants to lose weight found Ozempic to be a good helper, and that's very dangerous because they don't have diabetes. They are not helping them with diabetes, but they're having a lot of the side effects of Ozempic. That's all I can say about that.
Yeah, well, just a question.
I just did a review of that personal.
It was an excellent presentation, Dr. Simoes. I can say as a clinician, we are very excited about the potential of semaglutide and tirzepatide, which is another diabetes medication in the GLP-1 agonists. But you're right that it is being used kind of in pop culture inappropriately, and so having kind of negative side effects because of that. But in the right patient with diabetes or with severe obesity, we've seen some very promising results if they can tolerate the side effects or if they have access with their insurance. So I do think for us that are prescribing this medication, it's kind of an exciting opportunity because we haven't seen good medications for a long time and have been stuck with things like insulin, which contribute to weight gain. So there is a lot of potential clinically there with some of these medications. I had a question for you about your last publication that you were talking about with low rates of adoption with racial minority and low income users. Do you have ideas for what we can do to develop either new HIT or disseminate existing HIT to try to reach these groups of people that are being marginalized or being left out of the potential right now?
I don't have an idea how to get to them yet. I have general ideas, but I don't want to push them right now because I think we need to better understand what's going on with this population. For instance, the prevalence study that I presented clearly shows that they are not the main beneficiary of these, HIT technology right there. But is that true for our population? Maybe the studies are not. For instance, our healthcare system, MU, it's kind of a safety net in a way to a lot of people because we're academic medical center. So I think the absolute majority of the people in mid-Missouri who are diabetic and who are poor, who are minority, who have less education and low household income are being helped by our health system. So I don't think this is true everywhere. And in here, we could look into a study to understand how our system does better for this population than others, having a comparative data for another system in which this population is not well addressed through the treatment or management of diabetes. So I would love to design a study to do something like that. And I think Dr. Wakeman has brought us a lot more data than we had before. And I had a conversation with Dr. McClay, Jim, recently about that. And I think it's something I would like to explore with you, perhaps, and some of the other, Amy and the folks from the BMI team. How can we do a study like that using the PCORI network data, which is very large and includes a lot of other centers, of excellence in healthcare delivery? But by the way, this issue of the equity, I put that at the end because it's so big that our grant, which is only supposed to be focused on HIT now, it's being pressured by NIH to focus on equity. I haven't focused on equity issue at all. Even though I'm always being a public health and prevention guy, I always worry about equity issues. But in this specific, I was really more focused on the technology, on the health informatics of diabetes prevention control. But now we're being forced to think about it. And then coincidentally, this paper came out. You see, it's not too old. It's just recently, it was published in 22, which is clearly an open eye, kind of, okay, wow, we need to pay attention to that. But NIH already sent a message 3 months ago to all of us beneficiaries of this grant that I am. You're benefiting this seminar as part of that grant. It's one of the functions of this grant to share the knowledge with you. And they want us to think about how to focus on equity. And my focus on equity from this presentation, this review, is that the inequities outside the health system and inside the health system are not modified by health information technology. They may be even amplified, okay? And therefore, we need to study it, and we have data to do so. Let's study the amplification of inequities, and let's study the few examples. For instance, I believe, I don't have data on that, but I believe our medical care center, by being here for nearly 11 years now, 10 and a half years, I know that we deliver care to the absolute majority of mid-Missouri who are of low income and Medicaid patients, compared to the other group across the street, for instance. I'll give an example right now. Huge difference. Therefore, I believe that we do an excellent job in primary care and prevention, as well as treatment of primary care patients with diabetes, not the complicated ones. Go to our endocrinologist, we do an excellent job too. But I think we're getting them. So that allows me to say, okay, that's comparative data of a system that is getting to these people with a system that don't. See what happened that's different. See what are the factors before and after that. We can create kind of logic models, how these things work, and study it through the data. And we can even use machine learning to do that. Okay. So again, there's many opportunities here for that.
So we have 3 minutes left, and Dr. Pagano has a question for you.
Sure.
Okay, thank you, Dr. Simoes, for this wonderful presentation. What about paying attention to our patient family background? Because, for example, making use of your family experience, I diagnosed my husband, because he's polydipsia and polyuria, and that he has no evident signs apart from that. But when you think about it, her mother had a pregnancy diabetes, so it was expected for him to develop diabetes at some point in his life. Even so, he was a sportsman, so I think that I could check up on our patient's family on our interviews, could do a great job to start with, to know what to expect from these patients.
I agree entirely, Dr. Pagano. The family history has been a hallmark of medicine and history taking. So before the advent of genes, and I graduated way back in 81, so I used to take very careful family history, because you knew the genetics was very important. That's why we take family history. But it's something beyond family history, which is even beyond genetics, is the familial culture. Familial cultures change and affect everything in your environment. And people, in my practice back then at the time, I recall people say to me, well, why you worry so much about, I was already worried about the family or history. Meaning, if your family has a culture of eating some items more than other, they will eat all of them. It will pass on through generation. It's not really genetics, but it becomes, as the interaction between genes and environment becomes hard to disentangle there. So I'm with you, Dr. Pagano, but I think we have room for studies there. I want us to look into those research questions, and see how can we, this network that has attended this lecture, can partner with me and all the others in HDR network, and see how can we do some studies here using our data system to propose something interesting. We can start with a pilot, get some pilot funds inside our own organization, and then from there go to a grant, publish, get to a grant. I think it's useful. I would love to look into familial history. Actually, there is a paper, I can't remember the author, about 10 years ago, big paper on family history, because he was kind of upset because we put too much emphasis on genetics. And he was basically saying, what about the old genetics, which is family history and the anamnesis of a patient? Okay, that we get close to many diseases.
Of course, but today we have genes and epigenetics and also environment. We have to pay attention to all of this, influences on a patient's health. And regarding this, by the time I diagnosed my husband, I was working on a mice model and a rat model of metabolic syndrome induced by fructose in the drinking water. So I told him, because he was a Coke heavy drinker, like, if you stop drinking Coke, you could do a big difference. And he did. And in a month, he reduced his belly and lost a few pounds. So never gained them again. But was the realization that what his habit was doing him wrong. Like, because I was there to tell him every day that was a bad thing to do, right?
Right. For instance, I'll give every presentation I make on diabetes, I've said that I'm a perfect experiment, because I'm an identical twin, and then I don't have diabetes, I don't have hypertension, I don't have cardiovascular disease. My identical twin does. And he is 110 kilograms. You multiply by 2.2, you see how much it's in pounds. And he changed his lifestyle dramatically. And we are 67 years old, nearly 67 years old. He is frankly diabetic now, hypertensive, and has beginning of what I call the cardiovascular deterioration if he doesn't do anything dramatic right now. Okay, so that's a culture, that's a lifestyle, that's a family. because
Lifestyle,
I came
yes.
from a family that everybody is actually my father and my grandmother and my great grandmother, they're all extremely obese. Okay, so is that genetic? Is that familiar history? Is the family history? When I went to medical school, I changed, and I changed and kept it forever. I'm not saying I'm not gonna die of
Finally,
disease
it's
of diabetes
education.
tomorrow, but it's a perfect experiment. So again, we have room for research. Think about those research questions. Come back to us. We'd love to help with ideas where we can help with informatics. We have a great group of people who are really informatician. I'm a make-believe informatician. I'm just a primary care doctor who loves epidemiology and informatics and statistics for that matter. But I appreciate all your attention, and I think we are off time. And in respect of people time, I'll finish my talk. Dr. Kim, do you have any more questions there?
No, I don't see any more question. I just sent in the chat box for the next two scheduled our lecture series, one in October by Dr. Peter Cullen in the UMKC, and the other one scheduled in November by Dr. Amy Brother.
Thank you all. Thanks, everybody. Great discussion. Good points. Bye.
Thank you.